up for her presentation.
Thank you very much. It's a privilege to present this work on behalf of our team at Children's Hospital of Philadelphia and University of Pennsylvania. What I'm going to be talking to you today is an extension of the work that you saw Steve Grupp present. This is data from the initial phase 1 trial of CTL-019 showing relapse-free survival in this population of children and young adults with relapsed and refractory ALL. And we can see that in responding patients, the majority of patients will remain disease-free at 12 months with a 60% relapse-free survival, indicating very good outcomes, which you saw replicated on the global study of Tisagen-Lec-Lucel. And we have seen that in these patients who maintain disease response, the vast majority will have persistence of their CD19 CAR T cells. And we can measure that by seeing that their normal B cells, which also express CD19, will be cleared from the circulation by the effect of the CD19-directed CAR T cells. But for a fraction of patients shown here, we can see loss of that B cell aplasia. So when we see recovery of B cells, that is a marker of loss of persistence of the CD19-directed CAR T cells. And we have observed a higher rate of CD19 positive relapse in that group of patients who lose their CD19 CAR T cells prior to 6 months after infusion. So in this group of patients who recovered their B cells, indicating loss of CAR T cells, we started to think about how could we potentially improve upon the persistence and surveillance for leukemia and hopefully prevent relapse. Our hypothesis was that T cells, upon activation, may become exhausted through activation of immune checkpoint pathways, and that one such pathway, PD-1, may be involved in early loss of CD19 CAR T cells, and therefore that the combination with PD-1 checkpoint blockade may improve the function of the CAR T cells and their persistence. So in the group of patients who had poor persistence or partial or no response to prior CAR T cell therapy, we employed a combination approach with PD-1 blockade. With the schematic of the rationale being here, this is the tumor cell with the CD19 antigen and the CAR T cell with a CD19 directed CAR. The T cell activation upon this antigen engagement results in cytotoxic effect and killing of the tumor cell. But what can potentially happen with T cell activation is that there is checkpoint activation as well, either through ligand on the tumor cell or on cells in the microenvironment, and that can then bind to the checkpoint receptor on T cells and block the effect of the T cells. So one potential way to block that blunting of activation is through monoclonal antibodies directed against the ligand, and another method is through monoclonal antibodies binding the PD-1 receptor on the T cell. And so this is the approach we took in 3 groups of patients where we hypothesized that this pathway may play a role. So the first setting was in patients who had partial or no response to CD19-directed CAR T cells, where our hypothesis was that the activation of the T cells may lead to activation of the checkpoint pathway and block a full response. And in that group of patients, we added PD-1 blockade and saw that we unfortunately did not see an effect in this small group where 4 of the 4 patients treated had progression of their disease. One patient, this progression was marked by reduced CD19 expression, which was probably the mode of escape from CD19 CAR T cells. But in the second setting, in patients who responded to CAR T cells but had poor persistence, marked by early B cell recovery, we saw that patients who were reinfused with a CAR T cell product followed by infusion with PD-1 blockade, 3 out of 6 patients had a return of B-cell aplasia and sustained CR with B-cell aplasia, showing continued persistence of their CAR T cells. And then in the third situation, this was a little bit different than the other 2. In this situation, we had patients who had bulk extramedullary disease, and we hypothesized that the PD-1 checkpoint pathway may be activated through the microenvironment in that extramedullary situation, and added PD-1 blockade for patients who did not respond in their extramedullary disease, and saw that 2 out of 4 patients had a sustained CR, and 2 out of 4 patients had a partial response with the addition of PD-1 blockade. We saw that this combination resulted in few adverse events, and it was well tolerated. A few patients did have fever or grade 2 CRS, as well as cytopenias, but overall it was tolerated very well without serious adverse events. So in summary, we show that PD-1 checkpoint inhibitors can be safely combined with CD19 CAR T cell therapy, and that this mechanism may be useful to improve CAR T cell persistence. And we found that in half the patients, PD-1 checkpoint blockade can improve that persistence, and that this patient may particularly benefit patients in that situation with poor persistence, marked by early B cell recovery, as well as those with bulky extramedullary disease.
Thank you so much.